So wave 1 is outside CNS in the auditory nerve, and wave 5 is within the CNS. So normally wave 5 to wave 1 ratio is within 50 to 300%. So 50%, less than 50% indicates smaller waves of 4 and 5, that indicates central impairment, and more than 300% that indicates waves are better formed in wave 4 and 5 but not formed in wave 1, that indicates peripheral hearing impairment. So this wave 5 to wave 1 amplitude ratio is mainly used to differentiate between central cause and peripheral cause of hearing impairment. So what are the variables that affect BERA? As we saw in VEP, multiple variables can affect BERA recording. Again, age has a distinct effect on latency. Until 18 months, BERA is age dependent. Prolonged interpeak latencies in neonates has been attributed to improper myelination of the BERA pathway and improper synaptic efficiency of the higher order neurons. As myelination progresses, BERA latency also reduces. Compare older adults have slightly prolonged 1 to 5 interpeak latency by 0.1 to 0.15 milliseconds compared to younger adults. So latency difference is not by much, but in some cases that can be significant. Females have shorter latency and higher amplitude of BERA. Again, the reasons might be because of the head size. 1 to 5 latency is shorter by 0.1 millisecond in females compared to males. Absolute latency and interpeak latency are prolonged on lowering the body temperature. Again, as seen in the VEP, lower body temperature of males prolongs the P100 latencies. Here also, latencies can be prolonged on lowering the body temperature. Prolongation of P wave 5 latency with barbiturates and alcohol is also attributed to lowering the body temperature. Coming to clinical applications, mainly clinical applications is in the field of pediatrics, where we use the BERA for assessment of auditory pathway in neonates. In neurosurgery, when they remove the acoustic neuroma, and in cases of brain death assessment, this can be used. Again, in cases of malingering also, BERA can be used. So neonates falling into the high risk category need to be screened. So that has to be implemented within the first 3 months of life. A two-stage protocol of auto-acoustic emission screening is done, followed by BERA screening is usually recommended. In infants, OAE should be done before BERA screening. So BERA is usually recordable at 30 decibel. Any infant without any response at 30 decibel should be followed up again at 3 to 5 months of age. Repeat a BERA at 3 to 5 months of age. And it has been used to predict prognosis in anoxic brain damage. Reduced wave 5 to 1 amplitude ratio has been regarded as a bad predictor. So a single BERA is usually not useful in predicting long-term prognosis. So in infants, if you are assessing for hearing ability, you need to do multiple BERA at prefixed durations. So again, in spastic cerebral palsy, BERA can be abnormal. Posterior fossa tumors, abnormality again depends on the location. Where exactly is it? Monitoring the posterior fossa tumor recurrence following surgery or radiation therapy can also be done using BERA. Hydrocephalus, most frequent abnormality is decreased amplitudes of the later waveforms, that is wave 4, wave 5, those are usually decreased. Reduction in wave 5 to 1 amplitude ratio or absent wave 5 is also seen. So CP angle tumors, again, in about 80% of cases of acoustic neuroma, BERA is abnormal. This abnormality is usually seen as prolonged 1 to 3 or 1 to 5 latency, prolongation of wave 3 to 5 latency, right to left asymmetry again, and unrecordable BERA in some cases, like wave 1 is usually unrecordable. Coming to multiple sclerosis, BERA has been used to detect silent brainstem lesions and to document equivocal or uncertain symptoms pertaining to the brainstem. This can be used. Again, 87% of the cases, BERA abnormalities will be present with absence of wave 5, prolongation of 3 to 5 interpeak latencies, prolongation of 1 to 5 interpeak latencies, reduction in amplitude of wave 5 to wave 1 ratio, and absence of wave 3. So in cases of specific brainstem abnormalities in MS, we can use BERA for testing. Coming to coma and brain death, again, BERA as a prognostic predictor of coma and determination of brain death can be used. It is not a standalone modality that can be used, but it can be used in conjunction with your brainstem testing and apnea testing. So patients with coma due to metabolic or toxic etiology, BERA can be normal. Regardless of etiology and depth of the coma, recovery occurred in all patients with normal BERA. So in patients with abnormal BERA, in some cases, death occurred. So the relationship between BERA and prognosis is not always linear, as I said. So although consistent with brain death, negative BERA cannot be used as evidence that brainstem is non-functional. So this is an important takeaway point from this. So brainstem stroke also, it is employed in evaluation and prognostication of acute brainstem strokes. So if there is a pontomesencephalic stroke, then wave 3, wave 4 are usually found to be abnormal. So that basically completes BERA. Anything else?
I think it's very high standard presentation. So he interacted with the audience, looking at everybody, and it covered the subject very well. Very impressive.
Thank you, sir.
That mnemonic was very useful.
Equalize.
The people talk about
Oh.
We are not doing you're doing, sir.
No, sir.
It was not working. Now they got the software. Oh. Recently, see, you go back to slides. It says that all patients with abnormal BERA died.
No, sir. Like that is
I know. Coma patients
So-
with abnormal BERA died.
in that study that they conducted, they had that this thing. But even though it is so, it has to be in conjunction. We cannot take it as
It would mean a very bad prognosis. Regardless of etiology, regardless of etiology and depth of coma, recovery occurred in all those who had normal BERA.
because
all those were
in some cases of toxin, this thing BERA can still be abnormal, but in some case, like in this study, whoever had abnormal BERA died.
Yeah, but if that variation is there, that's why it's not used to certify brain death.
Yes, sir.
The brainstem is very resistant to many types of insults. That you can keep getting BERA even when the rest of the brain is different.
Yes, sir.
But when it is not recordable, it indicates a very severe brainstem. The experts say that in a short time covering two topics, all essential points have been covered. Very nicely done. What about 300 latencies when we use flash? Compared to pattern latency? Is there a difference?
I did not read up about that, sir.
The latency is same.
Yes, sir. I did not read about that. Like, I don't know, sir.
I don't think it's as reliable as a pattern because
In
it helps you to know if there is a response or not. But you can't use flash data alone to calculate any latency. It's not as reliable as pattern.
in Flash, it's only about whether it is present or not. You cannot do all the other things you said, no. Inter-eye variation, that this or that. That is not for Flash. Flash is only, is it present, not present. If it is present, it is considered okay. Because you cannot assess through other means, patient is not working.
Sometimes patients are not focus on the screen at all. Or they may deliberately, like you said, try to subject it. Then we go flash. If it is normal, we just say it is normal. But read if there is normally any variation between the different between pleasant development.
You have color blindness. So color blindness usually is for which colors?
Red green blindness.
But here we're using black and white checkerboard, no? So why should it affect?
Like, if there is two different types of color blindness together, then I think they use that chromatic this thing, like VEPs.
What happens if there is an occipital infarct?
Occipital infarct should ideally increase latency, sir.
You have the waveform, you not have the waveform.
Waveforms should be seen, sir, even in presence of an infarct.
You said now if there is absence of VEP
Yes,
in
sir.
accidental
Yes.
particle blindness,
Yes,
it carries a
Bad prognosis.
In general, otherwise, in regular stroke patients, is
Yeah.
it preserved or not?
It is usually preserved, sir. So if it is like absent, then the vision might not, he might not recover.
Is there something like that?
That they have said there is poor prognosis of recovery.
Can use it as a indicator of recovery.
Yes, sir.
Yes, sir. N75 P100 P1, but what is the reason for this waveform? Just like in BERA, you equalization, like what it means.
Oh,
Virgin of the
Virgin hospital.
You showed the
Yes, I showed how it occurs at the, but positivity, it is generated by the peristeate cortex. By why exactly is it in 75? I'm not sure, sir. In 145.
And P100 latency only unilateral anterior pathways. Why not posterior?
Posterior pathways, they might be prolonged, but if it is bilaterally prolonged, we will not be able to say that. If it is monoocular P100 prolongation, then we can confidently say that before the decussation, we were finding the lesion. So their P100 latency prolongation is quite significant. In bilateral this thing also, there might be prolongation, but we cannot exactly pinpoint where exactly is the lesion. Here you can say it is retrochiasmatic. There it might be chiasmatic, post-chiasmatic, it might be in the radiation. Elongation might be seen.
This reason to examine.
I'll have to find out. I'll tell you.
Your doubt is clear, right? Unilateral versus bilateral.
I'll take another. Next. SSCP and MEP together.
Yes.